Today we're going to talk a little bit about early intervention and standing. As Kyle mentioned, I've been a therapist, I guess it's going to be 35 years this year, so time really flies. I don't feel like it's been that long. I guess standing kind of became my passion. I went back to get my doctorate in 2007 and 2008. And as my final project for that degree, I did something on standing, and now it's kind of become a little bit of a passion of mine, and I just can see the difference it's made in the children's lives that I've worked with. In my history, I've kind of worked anywhere from birth to age 21. In the last several years, I've just pretty much been in early intervention and birth to 3 in White Bear Lake District. For those of you who are doing birth to 3, you know that the last year's been a little bit of a challenge because we haven't been able to get into the homes. Normally in Minnesota, we're going into the homes and doing our intervention. And with the pandemic, we've kind of been unable to do that. We've done a little bit of like some outside visits when we get in nice weather in Minnesota. And then fortunately in White Bear Lake, we've been able to do some in-center visits with kids. And that does make sharing that standing technology a little bit more challenging because you need to do a trial, you need to set up the equipment, you need to fit the children for it. And most of the time I'm bringing that technology to their home and doing it there. And we've just had to be a little bit more strategic in figuring out how to get those standards out to houses and how to get people all set up. But we've made it work in the last year, and hopefully we're going to start going back in the homes soon. All right, so we are going to get started. So we're going to talk a little bit about just figuring out when to start standing in your practice, go over some of the research that's out there and the different reasons for standing, and really helping identify what your goals are for standing, and then touch a little bit at the end on what types of standards and just trying to help you figure out how to choose the correct standard for your client. So I like to throw out all these pieces of equipment because if you're like me and you're going into the homes, you know they exist and they're not going away. I used to kind of have this hard line that no, we're absolutely not going to use these devices, but having been in birth to 3 and been in the homes long enough, even though I have a discussion about why professionally I think these devices aren't as appropriate, they don't disappear from the house. So that kind of tells me that kids are still getting into them and families are still using them. And so if they are going to be in the home, my discussion then becomes, what did they look like in this standard? Are we going to be able to get their feet flat? We don't want these young preemies that maybe we're working with jumping in a jumperoo and being up on their toes because we know they might have that inclination to be a little bit more stiff as a preemie, and we want them to outgrow that stiffness. We don't really want them standing in these devices asymmetrically if they don't have the control and the strength. So really trying to educate families on floor time is really important, and multiple positions are really important. And if this is something they need to use for a safe position for their child, trying to make sure that they look good while they're in it and really limiting it to just 10 or 15 minutes a day. So the other thing I should have said about those devices, if you read the labels on those, a lot of them are promoting standing for kids as young as 4 months old. Now, as a PT, do I really want the kids with maybe some delays or some tendencies for high muscle tone or some different things that we're really worried about developmentally standing in a jumperoo or another type of off the market device? Not really, but that's kind of what's being marketed to parents, and that's what everybody thinks they need, and that's what they get for the baby showers. So that's just what I want you to be aware of as a clinician. So for me, what I really look at for standing early If I'm going to use a standing device, I'm kind of targeting when kids are typically getting up and pulling to stand and going to stand, which is right around that 8 to 9 month time. That being said, there's some kids that I really try to have parents do some other things to try to promote some weight bearing on their legs, because we know those kids with low muscle tone, or maybe those kids with this little guy here is a little guy with spina bifida that I'm going to talk about. Some of those kids really need to start figuring out how to get that weight bearing through their legs. We know we have some very mushy kids who can't do some of that typical just weight bearing on mom's lap, or just doing some standing by being held by the trunk. I'll talk a little bit about this guy. He is somebody I started working with at the very beginning of the pandemic. So he's done great. He was able to start coming in this fall and into the winter a little bit with kind of a break in there to have a shunt put in. But he was born in a breech positioning, was born C-section, but he had breech positioning in utero. So he had kind of this right leg that wanted to abduct and flex and be out to the side. And then it wanted his left leg to come over. So he looked very windswept when he was an infant. And so watching him on all these Zoom meetings and trying to figure out how we're going to prevent that, I did end up giving mom a small pair of leg immobilizers that she could put on him and try to get some symmetry when she's doing some prone positioning and supine and sideline positioning. And then as he grew and got a little bit bigger, we exchanged those for something that fit a little better and had mom start trying to do a little bit of standing next to a ball. And this is something by then she was coming in center and we were able to do a little bit of, I'd show her how to do it and then she would try it and then she felt pretty comfortable doing it. And this is super important for these kids he's an L4 or 5 level kid with spina bifida. And I know down the line, he's at least going to be able to walk in a walker and be able to walk in the house. And I'm hoping he's going to be a little bit of a community walker, but until we get going, we don't really know. So we want to get some early standing and weight bearing for him before 9 months, but in a way that mom can still do it without having to have 10 hands. So this is kind of how Henry started. And now, because we've really worked on this a lot, mom can take those immobilizers off and he can do a little bit of standing by a ball with just his AFOs and his braces on. You can see when we're doing this kind of standing, we're not really able to target everything we want. We're not really getting good hip extension. He's got a little bit of a tight left heel cord, and you can even see that in this picture that we're not targeting everything we want to get, but we are getting some initial weight bearing. Okay, hang on, we got a little problem with, there we go. All right, so we'll go over a little bit of evidence, and I just want you to keep in mind, there's some good evidence that has a lot of really rigorous research, but then always remember that your expert opinion and what you've seen really work well in your practice is also just as important. There might be some strategies that you've used that just haven't had enough research to show that they're working. So I think we really have to keep in mind that we combine both of those things as we go through the course today. I want to jump in and just talk about some of the different benefits of standing and what some of the research is telling us. And I think a big one that's just been proven over and over again is that if we do some standing, we're going to improve the bone density of kids. And that's really important for, if you think of our population with cerebral palsy or spina bifida, those kids who, maybe aren't going to get enough standing on their own. And we know long-term down the line, especially those kids that are more involved in gross motor functional classifications 4 and 5, those kids really need a lot of standing because they're going to be at a higher risk of low bone density and fractures. A couple of big things to pull out of that is overall the studies they've done. I know they've shown benefits if you stand for an hour 5 days a week, but kind of the therapists that have done some cumulative looking at all the research out there are recommending 7.5 hours a week. So kind of an hour a day is the target. If you can get 60 minutes a day, you're going to really show some improvements in bone mass density. And that doesn't have to be all at once. That can be broken up in 2 or 3 sessions, whatever works for the child and the family. A couple of other things that are really noteworthy in some of those specific studies is they showed greater benefits if you had like some dynamic standing, and that could be vibration platforms, or that could be some just repeated loading, sit to stand multiple times. Not all of us have vibration platforms to use in our practice. I know we don't have one in White Bear Lake, but I do know that some of the private practices, it's becoming more common that they have some vibration platforms to do some treatment sessions on. So those are things to keep in mind, that maybe even doing more frequent standing sessions versus one 60-hour session um, makes a difference in that standing and bone mass density. The other thing you can think about is if you have somebody who's up in a stander and they're at home and they have that tray in front of them, trying to do just some functional activities on their tray where they're reaching a little bit to the left and the right and reaching forward and standing up tall and just doing a lot of that weight shifting while they're in the stander. And that's really going to help with getting that shifting and a little bit more dynamic standing while they're in their stander. All right, so the next thing I want to talk about is that prevention of fractures. It totally makes sense that if we're going to improve bone density, we're going to prevent some of those fractures. Again, as I talked about earlier, those kids in gross motor functional classification systems 4 and 5, those are her kids who are maybe going to do a little bit of in-house walking, but it's really not going to be functional walking. They might be walking just a little tiny bit at school just to get a little bit of functional walking, but they're not doing enough standing and walking um, by getting out of their chairs for transfers and just playing and FIAD and whatnot to get enough weight bearing. So we really need to get them up in the standards. We also know that a lot of those kids maybe had G tubes when they were younger and maybe still are G tube fed. And those tend to show increased comorbidity for not being able to absorb their nutrients and absorb that calcium. And so then they're at a higher risk. And a lot of those kids might have comorbidities of seizures, and there's that interference with being able to absorb calcium when you're on seizure meds. So it's really important that we keep that standing up. And I think as kids move through early childhood into adolescence, we have to keep having those conversations and talking about why we're standing and what our goals are for standing. And this for me is another big reason for doing standing, is kind of maintaining and improving range of motion. We know these little kiddos in birth to 3 aren't born with contractures typically. I mean, I do have kids in that spina bifida population that maybe have had some issues that we have to stretch them out, and some other disabilities where they might have some contractures at birth. But our goal a lot of times in birth to 3 is trying to prevent any contractures from happening, and really trying to keep their bodies as healthy as we can. So just trying to get enough standing so that we can promote that range of motion. We know the bones are going to grow faster than those muscles, and these kids aren't running and moving and playing and stretching to maintain that muscle length. So we've got to be doing some things to maintain that muscle length as those bones grow. Kind of the big dosage when they did a lot of research in this area is that 45 minutes of standing is really going to maintain and improve range of motion. And I've really seen this in my history and practice. I've had a few kids who maybe were going through, big growth spurt, and then they have that summer off and they get a little bit of tightness over the summer, and then we start them up in standing in the fall. They're maybe not standing as much as they should be, even though they have a stander at home, and they get back to school and we get back to a really regular, rigorous standing schedule, and we are able to regain all that range of motion, which is really nice to see. I've also seen some kids move into our district who were in that 4th, 5th grade level and had some hip flexion and knee flexion tightness, and I could not get full range of motion. So we started with some standing, and eventually were able to get them a little bit taller. We used some sit to stand devices, and we were able to stretch out his hamstrings and his hip flexors and get him fully upright over time. So I thought that was really nice to see, because having had him move into our district, I really didn't know how long he'd had these contractures. So it is something that really is helpful. And there's been some good research showing that with young kids as young as 14 months, that they can improve some hip range of motion. I've seen it over and over in my practice with, oftentimes you'll have tightness in the heel cord, and then you get them upstanding, and the parents will remark within really as early as 4 to 6 weeks that, wow, doing that stretch in their calf is super easy now, and I don't know if it's because they've been standing or what. And that's totally made a difference. Like, even my little boy with spina bifida, he started standing, and we did not have any AFOs for him when he started standing. And within a month of him standing, mom really noticed how easy it was to stretch out his foot, which was really exciting. So just looking a little bit at kind of the different ways of trying to stretch and do some standing. So we were able to really increase little Henry's range of motion by just doing some standing with knee immobilizers, because that made more sense for him under age 9 months. And then I got him up in a stander because I really needed to get more symmetry and more weight bearing. And it's not really reasonable for mom to be able to stand with him by a ball or stand with him by a couch for 60 minutes of standing or 45 minutes of standing. So we did get him up in a stander when he got closer to 9 months of age. And this little guy on the left, you can see he's using a standing device that allowed him to stand with hip abduction. And there's been some nice research in the last 5 to 6 years that really has looked at being able to maintain range of motion in those hip abductors over time. They did a really nice study that looked at standing kids from as young as 9 months all the way up to age 5, and these were kids with cerebral palsy, where they were able to maintain their hip abductor range of motion, which again then leads to better hip integrity down the line. So we know that if we can implement some of that standing and hip abduction, we can maintain the range of motion in those hip adductors. Kind of to segue into that, I think it's really exciting that we have the standing technology to stand in hip abduction, because we really need to, as therapists, be on top of helping monitor that hip joint integrity. I think I kind of had a really good learning moment, and this was sort of before the hip abduction technology was available and being able to stand kids in hip abduction, to now being able to see the outcomes of my kids are a little bit different since starting that technology. But I've also learned that I really need to request those reports from doctors. So if you can request all those hip x-rays, you can kind of follow as a therapist, is it kind of moving in the wrong direction or not? So when kids are really young, they're going to start with just an ultrasound, because you don't have enough bone density to really show anything on an x-ray. And so then they're going to be measuring this alpha value, and you want to see that alpha value be at the right range. So it needs to be 60 degrees or greater to be kind of in that normal range. And then around that 9-month age, you're going to see kids kind of switch to having x-rays where they're measuring what's called the acetabular value. And you want to see that to be under 30 degrees. So a lot of the literature kind of says 28 degrees is normal value, but I've seen doctors sort of say anything 30 and under is good. But the important piece is to really watch, if your kiddo had an initial x-ray and things looked really good, make sure you request that next x-ray so you can compare the values, because you want to know if things are still moving in the right direction, or if things are sort of creeping up towards that 30-degree value. And then you want to know when they start to creep over that, because doctors don't always share those numbers with parents, and they kind of will just say, yeah, things are looking good. even though maybe the last 2 to 3 x-rays, they're starting to see a trend in the wrong direction, they don't always let parents know or make parents worried about those things because there's so many things to worry about. Um, so that's something I've sort of learned over the years, that I want to make sure I'm getting those x-rays and those numbers and really watching and trying to educate the parents on what that actually means. And you have some good doctors that are really going to explain it, and then others that are maybe just going to gloss over it. And we know, just looking at that incidence, it's definitely going to be higher with those kids with cerebral palsy. There's a pretty high incidence of 35%. But I want you to be aware it's not just a high tone incidence. So it's not just a condition with high tone, and I've seen it a lot with low muscle tone. And I'm not sure about the rest of you out in the therapy world, but I feel like we see a lot of low muscle tone now, more so than I did when I first got out of school and started as a therapist. And I'm seeing even more hip dysplasia with those kids than I used to see. So for whatever reason, we need to really be careful and watch that as well. And spina bifida, of course, is another thing with the asymmetries in spina bifida. That's something that you're going to have to watch and monitor their hip joint integrity. A couple other things, just kids born with breech positioning are a higher risk. So my little guy with spina bifida, I've got to watch him a little bit more. And then twins or multiple births just have higher risk, which in general have higher risk for developmental delays as well. So this kind of makes sense, what leads to hip dislocation. You know, if we have that spasticity in the muscles, and as kids' bones grow, their muscles aren't going to grow at the same rate because they're not moving and stretching on their own. So then we start to get that pull. And what happens to those spastic muscles? Well, they like to adduct and they like to internally rotate. And you think of that kind of that diplegic tone, where that's like what they like to do is scissors. Those muscles just want to pull across. And the tone in those muscles really makes it difficult to build up the opposing muscles and the strength in those opposing muscles. So if we as therapists can maintain the range of motion in those spastic muscles, we've got a much better outcome with being able to build up that hip extension and that hip abduction, those things that really are going to help oppose pulling those muscles in. In those kids with spina bifida or maybe low muscle tone, it's really that weakness. And so they don't have the strength in their hip extension and abduction, and then they just start to collapse inward because they don't have that control. So just being aware of those things and trying to help with that. You know, and if you've been working long enough, you've seen kids go through surgeries, and it's just not fun for the families, and it's traumatic and it's hard for the kids. And I've had a lot of kids who have gone through hip surgeries and really been hard to get them to move again when we're done. Sometimes you just have to start doing some biking or some other things so that they are not afraid to get back up in their stander, because it's not really easy to transition right back into what they were doing pre-surgery status. We know there's a lot of research out there that if you can get kids up to like age 6 before they have their first surgery, they're going to have a better outcome. If kids have their first surgery under age 6, they tend to have a lot of repeat surgeries, or they maybe just aren't going to hold. And those also can be the kids who are maybe are even more involved and have more dystonia mixed with spasticity, and it's just harder to manage their hips because of the tone. I would say the complication rate is pretty high when I look at the research, up there towards 50%. You don't see as many spica casts anymore. I typically see kids in long leg casts with, or else bilateral knee immobilizers with some sort of a foam wedge in between them. So a kind of a combination of that. Higher complications with the spica cast, including like some kids fracturing within the cast because they're moving around a little bit too much and then fixed in that position. So those are a couple of the risk factors. And again, I think if we can get kids to over age 6, it's a huge win, because then there's going to be fewer complications with their surgery. And I think this group over in if you look at some of the biggest research, there's a group over in Sweden who has done a really good job with over 20 years of trying to just manage hips in kids with cerebral palsy. They do a really good job with hip surveillance and tracking and monitoring every child. And so those kids are often having some preventative tenotomies just to try to prevent those spastic muscles from becoming so strong that they do pull kids out of their hips. And they have some really good monitoring with some positioning at night, positioning in a seated position, and then doing some standing. So they're really looking at sort of a 24-hour management of kids posturing over in Sweden. And they've had some really good results with looking at controlling their posture in all those positions. So I think hopefully in the United States, we're getting better at monitoring all those things and getting some interventions a little bit earlier. And then again, I think I talked about this a little bit, that the risk as kids get, if they have surgery under age 7 or under age 6, that risk is a little bit higher for needing surgery again or failed surgeries. But even if you look at what the risk factor is at age 7, our kids are still pretty high risk for having hip integrity issues. So we can't really just think we're out of the park if we get to that age. We still have to really stay on top of it. And a lot of growing happening all the way through those adolescent years. And if we can get kids through those years, I think then we're going to be keeping them out of surgery, which would be exciting. So I alluded a little bit to some of this new research. I'd say in the last 5 to 6 years, we've had the most research with publishing things where they've really looked at doing some standing programs in abduction. I talked about the one research where they stood kids and they actually made their own standers when they did this research. They had kids in a cast stander that was in abduction. So they basically made these plaster standers and stood kids in abduction, and they were able to really maintain the range of motion all the way through 5 years, which is exciting. I think what's even more exciting is if we can do some consistent standing and abduction, they're starting to see that we can actually make a change in migration percentage. So if you've got a kiddo who's starting to migrate, their hip's starting to migrate out of their socket, you can actually do some standing and abduction and improve that migration percentage and tighten up that socket and build a better acetabulum. So it's going to be up to us as therapists to make sure that we're promoting that kind of a standing frame if that's one of our goals and those kiddos are showing that need. And this is some really great research. You can just pull these studies and put them in with your letters of medical necessity if that's something you're promoting and that's one of your goals. I just wanted to talk a little bit about these two little friends of mine. The little guy on the left is somebody I worked with low muscle tone, and he is 6.5 years now. And then the little girl on the right had higher muscle tone. And I worked with her up until when she was 3. And when I was working with her, the standing technology, this is the Zing stander for standing and abduction, was just coming out when she was going to turn 3. So we were getting her to try a stander and ready to order her one. And then she went back to her doctor, and all along the doctor had said, yep, the hips are looking good. You're doing well. We were kind of supporting her in just a regular stander with no abduction because that's all I had available. And really watching her positioning when she was seated and doing some good things with her when she was lying down and playing. And she was pretty involved, and she did need a lot of support. So she went back to the doctor right before we were getting ready to order this stander and found out she needed to have hip surgery. So parents kind of wanted to push waiting to order the stander. And so she did not get her first stander with the abduction until after she had turned 3. And I always wonder with her, had we been able to do some standing right away from the get-go at 9 months, could we have made a difference in what her hip outcomes would be? And that's not something I'll ever know, but It's something that I wish I would have had that technology. She ended up having an additional surgery when she was 4.5. So she's already had to have 2 surgeries by age 4.5. And that little bit of me always wonders if we could have made a difference if we would have had that technology available. This little guy on the left is somebody with Emanuel syndrome and low muscle tone. And he was born and found out he had hip dysplasia very early on at 6 weeks. So he wore the Pavlik splint for a long time at night. And then eventually, right around 8 to 9 months, he was able to decrease his time in the Pavlik splint enough that we could he was in it for 23 out of 24 hours. So there was not a lot we could do therapy-wise other than working on some head control. But he finally got out of it enough hours of the day that we could try to introduce some standing technology. And that's right when the Zing was coming out. So he was one of the first people I tried in it. And when we first got him in it, having been in that Pavlik splint for months, he had kind of some hip flexion tightness, and he just kind of looked like a frog. That's how he wanted to be. So we had to accommodate some of that positioning and just really gently get him into more extension all the way down his lower extremities. We also started him, he's shown here in the prone model, but we started him in a multi-positional stander because he really didn't have the head and trunk control. We had to really load him in a supine position and then get him all strapped in and get him upright. And we couldn't even get him fully upright for several months because he did not have the head and trunk strength. And that makes sense because he'd been in that Pavlik splint for so long. There weren't a lot of positions they could put him in during the day that didn't give him that support and leaning backwards. So what's cool about him is his doctor predicted that he was going to need to do hip surgery on him by around age 2.5 to 3. And he eventually adapted to the stander really well, and they would stand for at least 45 minutes twice a day, sometimes longer. He loved to watch TV in it. He would play with his toys in it. He would throw toys on the floor too. He'd have his snacks in it, pretty much anything. And we ended up bringing him from a supine to an upright and then some working in prone, which you can see here. And really working in prone for him helped him develop a lot of upper body strength and a lot of head and trunk control strength, and really helped him gain some independent sitting down the line. So when we were ready to order him a stander, I had the luxury of having some loaner devices that I could give the family for a while. We did end up just ordering him a prone stander because he had made so much progress by then. We're going to talk a little bit about improved motor skills, and you've probably heard as I've shared some of these examples how just standing has really improved some kids' motor skills. And that's probably the number one reason I am standing kids as a clinician in birth to 3 is I know it's going to improve my kids' motor skills. And, I can only be there 1 hour a week, and parents can only do so much, especially if they have other kids. So being able to have some other sort of therapy thing that's going to improve things without a lot of hands-on is pretty exciting. So a lot of research out there supporting that. Pretty exciting. This really makes sense. The first one that, we can improve stride length and stance time and all those things. If you think about kids with higher muscle tone, if they can get up and stand in a stander before we do some gait training, they're going to just sort of have that motor learning to be able to get down and do some walking afterwards. And I've used this to my advantage a lot in birth to 3. I'll have the parent, especially if it's a kiddo with higher muscle tone and we're working on some gait training, I'll have them get them in their stander before I come for my home visit. And then we'll work on a little bit of gait training in their walker right after we get them out. And then we can finish with our other therapy ideas. And then parents are able to learn how to walk with their kids a little bit easier because we've sort of decreased that tone from standing and given them a little bit of motor learning from standing, and then they're ready to do some walking. The other exciting thing I think is just the fact that they showed some increased scores on standardized testing with fine motor skills while kids were standing. So that just goes to show that there's a lot you can do up in a stander. It doesn't really limit your functional ability with your hands. I would say that on the opposite, I've seen kids really improve their upper body strength. If you think about kids standing, even if they're only upright, they're leaning on that tray with their elbows, they're leaning on there with their upper body, and they have a surface that's right there in front of them, and they're well supported so they can use their arms and their hands to play. And if you're using some sort of a multi-positional stander where you can go from upright and work a little bit in prone and in a position that's going to challenge kids, you can even build that upper strength a little bit faster. I just want to talk a little bit about this little guy because he's a prime example of the kind of functional gains I see with getting kids standing. He's somebody that I started in December during COVID, and they did not want to come in center, and mom's the director of a daycare. So I ended up getting him fitted for a stander. When I first started him, he was 2, not able to stand on his legs. I mean, with all my strength and everything, I really could not support him and lean him against the surface and try to get him standing. And he's 2, so he's pretty solid and weighs a decent amount. He stood with his arms back and he did not play with anything and he didn't want to touch anything. And so really trying to lean him forward and have him help with his upper body really didn't help. So we got this little stander out to his daycare, and this is probably one of my favorite first standers to use with kids. You're not getting any abduction when you're standing in here, but that really wasn't my focus for this kiddo. My goal for him was to try to find a functional way for him to play. He was sitting, but if he used his hands in sitting, he would fall over pretty easily. And he wasn't doing a whole lot of functional play other than maybe helping turn pages of a book. He wasn't grasping toys or anything. So sitting was such a challenging position still that I wanted him somewhere where he could be independent. So we got him up in the stander maybe the second week of December. I got to do a couple virtual visits, and then it was Christmas vacation for school, so I had 2 weeks off. I came back in January and did a virtual visit, and all of a sudden here he is leaning forward on the tray, starting to kind of rake and grab at the toys on the tray. And even though he is in a daycare and we're not really going into homes, they were able to set up a situation where I can work with him in a private room with nobody there other than mom. So I have now been seeing him in the daycare a little bit, and I could stand him up now, and he totally takes all his weight. I can start to take steps with him now. He's grabbing toys. His favorite thing though is to grab your mask. So he not really very motivated by toys, but we found he's super motivated by masks. So now we just have like a pile of 4 or 5 masks that he has to pick up and then put them into a bucket. So we found the things that he's motivated by, and it's only April. So this is less than 6 months, and we've seen huge gains in him able to hold his own weight, being able to facilitate walking for 20 to 30 feet across the room, and him being able to use his hands now for things that he's motivated by. Maybe not the things we're motivated to have him do, but he's motivated to grab your glasses and grab your hair and grab your mask off your face. So those are the things he likes to do. And I can't really attribute that to things that mom was trying to work on with him or things that I was working on him with in therapy. It's really due to being in a stander, because I could not have made that amount of progress that fast. And then I talked a little bit about decreasing tone earlier when I was talking about some of the functional gains with standing, but there is some really good studies showing that we can decrease tone by standing for 30 to 35 minutes. So that is awesome, that we can get kids up for a half hour of standing and decrease their tone, and then get some really nice functional outcomes with being able to do some stepping and walking afterwards, and even just making kids more comfortable because their tone is kind of controlled and reduced. So that is a great outcome from standing. And oftentimes, because I know that standing for 30 minutes is going to decrease their tone, I might have somebody really try to do twice a day, 30 minutes. So we're getting to that hour, but we're doing it in 2 segments, because I know that's going to really kind of keep that tone reduced, which is super important as kids are growing to kind of keep that tone under control. Not a lot of studies on standing and constipation, but I bet if we had everybody raise their hand in the hand function right now in the Zoom meeting, that every therapist who's done standing with kids knows that standing really helps kids have better relief. And this study I think is kind of cool because they took a kiddo who, and I don't recall the age of this guy, but he was, I believe, like middle school, high school. Anyway, they took somebody who had never used a standing device before with cerebral palsy and had needed an enema 100% of the time to go because of pain and because he would hold it and he was afraid. And they put him in a stander. First, they did a baseline of 14 days of what he was doing with his bowel movements. Then they put him in a stander for 21 days of standing. And by the end of that, he needed no enemas. He was going on his own. He had no pain and he was so much more comfortable. And this kiddo had in and out of the hospital with bowel obstructions. I know several children and probably more adults, like kids that I used to treat over my 35 years, who have been in and out of the hospital with bowel obstructions. And I remember doing a class a few years ago on like just the cost effectiveness of standing. And if you look at getting somebody up and standing, what you can prevent, and you go in the hospital for a bowel obstruction and you're talking at least $35,000 for that hospital stay. And that's only a couple of days, assuming that you get it figured out in 2 days in their home. So we could buy a lot of standards with $35,000. So I think that despite the fact that there's not a ton of research, this is a perfect one to cite if that's your reason for your goal for standing. And I think this pretty typical with most therapists that work in the school district. We know getting kids up and standing, it just kind of helps other kids in the classroom interact with them better and look at them differently and be like, oh, I didn't, if they're always in a wheelchair and then they see them standing, they're like, I didn't know that they could do that. And just really helps other kids be more comfortable with interacting with them because they're up at their level then. And this is just a picture of a little guy I used to work with that his sister always helped him like interact with his toys and do different things while he was in standing and entertain him while he was in his stander. So this was a good picture of how he used his stander a lot with his sister. And then I just want to touch real quick a little bit on how you want to pick a stander. I think you have to kind of look at what your goals are. Do you have a kiddo with high muscle tone? Do they have hip integrity issues that you're worried about? Or if they have a high muscle tone and they're little itty bitty and maybe they don't have any yet, from prior experience that probably they're at risk of that. So that might be one of your goals. And then we also have to look at what is their muscle strength and their muscle control, so that that they can handle standing, because we want to be able to have kids meet that dosage of an hour a day. And if we're not meeting the dosage that research is showing, then you pick the wrong stander. So we've got to have the right kind of standard to help meet some of those goals and dosages. So if they don't have enough head control and enough trunk control to be able to be upright for a whole hour, and they might get fatigued and have to lean back and supine, then you really need to get a supine stander. That's not to say that you can't get something that's a multi-positional where you start in supine and then you work to upright as they get stronger. You might work upright and then work to prone a little bit to get them stronger, but you have to probably start in that supine position if they don't have the head control. And I have a lot of kids who are never going to get the head control to be able to stand completely upright, but they do really well in a supine stander. And you can look at different head supports and try to get enough control so that they're not falling off the headrest too. So sometimes I pick up on the upper left, the Pro Mobile Stander. I'll often pick that if my goal is to get kids moving and independently exploring, and maybe they're not ready for a wheelchair at home. It kind of depends on where the family is at. I have the luxury in my birth to three setting, and actually the whole time I've worked in the school setting, of sort of having this large lending library of standards that I can loan out to families. We can try for a while. And then I'm limited by how many kids I'm seeing and how many kids need standards. So if I have somebody who a stander is working really well, but I don't really have anybody in the wings waiting for that stander, I might let them use it longer because they can just keep using it, and I maybe don't quite have the time to order a stander at the moment. Other times, if I have all my standers out at people's houses, then I have to be a little bit more vigorous about figuring out what's going to work for them and getting a stander ordered so that I can get my standards back in center and loan them back out again. But the Pro Mobile is great. I've ordered that for some of my kids with spina bifida, where they're getting closer to that 2.5 to 3 age, and the parents still aren't really ready to have a wheelchair in their life. And so then we look at something that maybe will give them another way to be mobile. And so that's often when I will get that one. And that's assuming that there isn't anything where I'm worried about their hips. So you kind of have to balance out what your priorities are and what the family's priorities are, and then figure out what's the best one. The middle one is just more of a upright to prone stander. It's called the Ormesa Dondolino, and that's an easy one for families to use because you basically just strap them in with a strap behind their buttocks, and then you can see their knees kind of fit into the knee cup. The problem with that one is if they really don't have enough trunk control, they're going to do a lot of leaning laterally. And so if they don't have that ability to hold their trunk up, you may see them lean this way, or you may see them lean that way. And then it's not really enough support for somebody who can't control themselves medial-laterally and hold their head up that whole entire time. And then you'll see the new Zing that is on the right there, which is a portable stander, and that's great for birth to three, where you really need that portability of a stander, because you can basically fold it up, put it in a car, bring it to daycare if you needed to, bring it to grandma's house if you needed to. That I think is going to open the options for kids to use their standing devices a little bit more when they're in that early intervention phase. I've got some kids who, are home 2 days a week and then in daycare the other 3 days a week. And then, by the time you're done with daycare, if you're a parent, it's really hard to get that standing time in. So, and it's not feasible to be lifting up a big heavy stander and bring it to grandma's house where maybe they're being watched, or to daycare. So that's kind of a nice option, and it gives us also the prone, supine, and hip abduction option, which is really nice. Just a couple other ones on the bottom that you can see. Don't use the one on the left a whole lot anymore because I don't find it gives me as good of alignment. But the Squiggles has been one that I've used, and then you can see the Zing standard. The difference between those is with the Squiggles, you can't really do any hip abduction, but it does give you a supine option for getting kids up and standing if you need that. And this is just a few. I mean, I know there's a lot more out there. It's more, these tend to be the ones I use because those are available in my closet to try. And then if there's something new I need to try, I try that as well. So who provides the standard? Like I said, I'm very blessed and have the luxury of having a bunch of them in my little loaner closet to loan out. But then once kids are getting close to age 2, I really try to get them a stander ordered if they're going to need one long term. I do have kids that I will maybe just use a stander for 6 months. My low muscle tone kids, some kids with Down syndrome and a lot of sensory needs. If we can't really get them weight bearing on their own, we'll get them up in a stander around 9 months just to really try to get enough weight bearing and strength going. And then they might progress out of it because they've gotten strong enough that we can do some other things. And that's something have the liberty to do. I know everybody doesn't, but you could kind of think out of the box and maybe use neomobilizers if you don't have that ability and you're not really sure if this is something they're going to need long term. If you think you need to purchase one, then you just need to kind of work with your local vendor and figure out, do they have medical assistance? Do they have private insurance? Who's going to cover it? I know a lot of school therapists are worried about recommending products because they're afraid the school is going to end up having to pay for it. I think if you start that conversation with, this is something we can try, it's not something the school district can pay for, but we can try it, and these are the benefits, and then this is how we would go about getting it covered. I think most families are very reasonable. There are a few school districts I know in Minnesota that use their medical assistance, third-party billing money to buy specific standards for kids in the school district. So I think that happens more in that kindergarten to 21 range where they're going to use it in the classroom. But that's kind of been my experience with it. I help them figure out who they want to go through for a vendor, and then we figure out what they're going to do and do our little standard trial and write up our letter of medical necessity, and that's how we get it covered long term. And then I just wanted to summarize real quick so that we can kind of remember what the dosage is. So when you're thinking of your goals, if you're really wanting to build bone density or range of motion, or if it's your hip integrity, you can kind of get everything if you get 60 minutes a day. So think of what your goals are and make sure that I think it's really good to share with parents that, these are the dosages to meet our goals that we're shooting for with standing. And I know we're getting really close to 11. So with that, let's quick open it to questions and answers.